Hi, I'm Dr. Bojana Jankovic Weatherly, and in this episode, I talked to Dr. Elizabeth Raskin, who is an integrative colorectal surgeon. We talk about this concept of integrative surgery and how Dr. Raskin has implemented this into her practice of surgery and how her practice has evolved over the years. We discuss why practicing integratively is really important for the patient experience, as well as potentially for patient outcomes, as well as the provider and the team experience overall. We talk about how she engages and supports her patients in this very vulnerable state from the time they walk into her door, during surgery, as well as post-operatively during the recovery and rehabilitation phase. We talk about the concept of healing and what this really means, and just acknowledge the fact that there are some very tangible outcomes that we can identify and measure. And there's still some intangibles that are also very important to consider when we're talking about supporting people heal, and whether it's in a surgical specialty or non-surgical specialty. And we also discuss the culture of medicine, as well as the self-reflection and awareness that's really important for all physicians and all providers out there for our own self-care, but also to enhance the experience of our patients and to really engage with our patients. I hope that you find this conversation as interesting as I did. I certainly found speaking to Dr. Raskin fascinating, and really think that whether you're somebody who may be interacting with the medical system as a patient or have a loved one that you want to share this with, I really hope that that will be useful for them in their advocacy journey and in their patient empowerment. But I also hope that if you're a physician, if you're a medical provider, that you will be able to take away some tools and some food for thought in terms of your own practice. I hope you enjoy this. Today in our conversations, we have Dr. Elizabeth Raskin. We're going to be talking about integrative surgery, such a novel and interesting and necessary topic that I'm really, really excited to discuss with you, Elizabeth. Just to introduce you to everybody watching and listening, Elizabeth is the Chief of Colorectal Surgery and Surgical Director for the Margolis Family IBD program. That's Inflammatory Bowel Disease program. She has an integrative surgical practice and is associated with Hoag Hospital in Newport Beach, California. As I mentioned to you before, Elizabeth, I'm so impressed with all of your training, and you're currently completing your integrative medicine fellowship training, which you're adding into your practice of surgery that you've done for many years. And this is what we're going to focus on today. Elizabeth's surgical interests are inflammatory bowel disease, reoperative surgery, and robotic surgery, as well as diverticular disease and colorectal cancer. And Elizabeth is a recipient of many awards and recognitions, and you also do humanitarian mission work as well. And in addition to all of this, you're a wife and a mother, and you do endurance athletics, and also have some very kind of creative and other gardening interests as well. So hopefully we'll kind of get to dive into everything during our discussion today. Thank you so much for being here.
Thank you for inviting me. This is so exciting because we know each other through integrative medicine, and I have always wanted this opportunity to talk about integrative surgery, which is this new branch, I think, of surgery that is so needed, both from the patient's perspective, but also from the practitioner's perspective.
I couldn't agree more. And I remember when you first shared about this topic in our small group session, I'd never heard about it before. And reflecting on it as a primary care physician in the past, I've done so many pre-op consultations, and this is, something that in primary care we do routinely. And it's so interesting as you started to talk about this, and as I started to do a little bit more digging about it, how much we can really impact the patient experience, the patient outcomes, our own experiences as providers, as physicians, and how what are all the things that we can do that we're not currently doing in those different stages as somebody is getting ready for surgery, during surgery, and post-operatively.
That's right.
Let's talk a little bit about kind of the framework first. Maybe we can just kind of name the framework. And then I want to sort of start at the beginning, because I think that you do something really interesting when you first meet patients. And I want to kind of talk a little bit about some of the questions that you ask and how that relates to the patient themselves kind of starting to make sense of the meaning of their condition and the beginning of their healing.
Yeah, I can talk about that. I mean, I think a good way to start is to maybe even define what I mean by integrative surgery. And I have used this or created this definition of it being a multi-layered approach to surgical care that basically focuses on the patient's innate healing capacity. We don't commonly, as surgeons, get training or think really about how can a patient heal themselves first and then finally. When they come to us, we're taught to fix things. And I think that's an area that we can dive into that is really, I think, takes us down the wrong pathway in terms of complete health for a patient. But so we start with enhancing the patient's innate healing capacities. We start thinking about what are those metrics, those perioperative metrics that can be altered or changed. So basically modifiable risk factors that can lead to poor outcomes or the lack of healing. We, of course, want to reduce suffering. And ultimately, our goal is to basically restore whole person health. And all of this is predicated upon what is that patient-surgeon relationship. Instead of it just being the patient comes to me and I say, oh, you've got this broken, I'm going to go fix it. And then you're on your way, and then it's relegated to other providers to finish the healing, to finish this process. Surgeons need to take ownership of this journey that patients are on, because surgery, by definition, is traumatic, right? And we don't say that outright very much. We talk about trauma surgery when you've been in a car accident or you've been injured. But there is this concept of the trauma of surgery that I spend a lot of time talking to patients about. And I think there's also something to the training in surgery that can be very traumatic to the practitioner. So when we think about integrative surgery, we're addressing both of those issues. What are the traumas that we as practitioners have carried with us, even though it's been in the name of becoming better doctors or learning and training in a discipline? But that traumatic experience gives us a lot of knowledge or wisdom, if we tap into it, that we can relate to a patient's journey. But we're not talking about this as surgeons. I am, of course, but we're not naming it that. The trauma of surgery. This comes into discussing how we're treated as medical students and interns and residents, and the sort of abuses that occur in the field of medicine and surgery that have not been called out. I mean, we've addressed duty hour, excessive duty hours as being really pathologic and dangerous to patients' outcomes. But the way that we're talked to, the way that we're taught, the things that we're supposed to put up with because we're supposed to be able to be tough enough to get through this, honestly, are abusive. And I call it the, like surgical sadism and surgical masochism that we put ourselves through for the sake of earning a place in this league of elite doctors, so to speak. But I also think that that is so detrimental to our own personal well-being. We have to start talking about it. And we've got to train our students and our residents and everyone across the board in a way that you don't think of that yelling and that abusive behavior as normal. That's not normal. I don't yell. I've never yelled in the operating room. I've never yelled at a person, ever. And that's because I think through my training, I realized how harmful that is. It's harmful to myself and it's harmful to the people around me, but it's also harmful to the patient if you think about it in an energetic way, right? To have this energy in a room that is so destructive does not promote healing. So, this is where I got started in this concept of blending integrative medicine, surgery to heal myself, to heal patients, but also to create just a really tight knit and healthy fabric of the team that surrounds a patient. Because we don't, as you know, do this on our own.
Yeah. And let's go back a little bit. I'm curious to hear, how did you choose surgery?
It's so funny because I've known my whole life that I wanted to be a doctor. My first recollections, I've told this story to some of my residents. When I was 4, my father was a fellow in rheumatology, and he had an office in his basement and would practice his carousel slide talks by projecting slides up onto the wall of this, whitewashed wall. And I would sit there and like folded, crisscross legs sitting on the carpet and watch what he was talking about. And he'd show these beautifully stained slides of inflammatory processes. And as you know, when you see those kind of colors to a child, that looks like artwork. And somehow I knew as he was giving his talk, and I was his sole audience member, I somehow knew I wanted to know that wisdom that he did. There was something about what he was describing and the way that he was talking about his patients, and just this desire to make people better. I said, I have to do this. I have to be part of this exclusive club that has this wisdom, this knowledge, but also has the capacity to help our friends, our family, the people around me. So at the age of 4, I knew I wanted to be a doctor. And then as I went through life, there really wasn't much exposure to surgery. We didn't have the movies and the TV shows that you do now, like Trauma, Life in the OR, ER, whatever it is. The one television show that was out there was MASH. And MASH, many of our new listeners, younger listeners don't know that television show, but it was a television show that basically focused on an American military hospital in the Korean War. And it was a comedy drama. And so what they did was they took this really serious topic and they added elements of humor to it. And these were people working, saving people's lives in the battlefield. And I just remember watching the individuals interact in the operating room and thinking, this is mesmerizing. Like what I'm watching of this room where they used humor to diffuse really awful situations where patients died on the show. They were horribly injured. But the funny thing about that show is that in a lot of comedies, they use canned laughter, and they use canned laughter in that show, but never in the operating room. Isn't that funny? I mean, not funny, but it's a kind of an interesting choice of the director, right? To use that laughter outside of the operating room, but in the operating room, it wasn't that. And so I said, I've got to do this. I've got to, whatever this is, I've got to do this. And this was me as a 7 or 8-year-old. And then as I got through college, I was able to become a surgical tech after college before I even applied to medical school. So I worked in surgery at the very lowest level, from an instrument technician, cleaning instruments, mopping rooms, cleaning and turning over the operating room, doing EKGs, drawing blood. I really knew the ins and outs of what it took to have surgery accomplished. Of course, I didn't know any of the anatomy, the physiology, the indications, or the technique, but I knew a lot of what it took to be in the operating room. And it's interesting because even these things I talk about in training of being, kind of abusive and being yelled at, I experienced that a tremendous amount in that role. And I remember telling myself, because I was just 21, 22 years old, I said, I want to do this, but I don't want to do it like that. And I knew that as I went through my own training, there had to be a different way that we could approach our work. You didn't have to be this megalomaniac, tyrant personality that you see in TV and movies. There's a different way to do that. And I think this is what my integrative surgical practice has become, is a way to showcase that those elements aren't part and parcel to successful outcomes. You don't have to have people fear you as a surgeon or as a doctor. There's a completely different way that you can bring people together to synergistically offer a patient healing. And that's where it all started.
And you're really leading by example. I love the story that kind of just of how you came to be where you are and the elements that you were really inspired by. I'm curious, what do you think contributes to that culture in surgery, right? So the culture that you generally described, right, that we are exposed to in our training as medical students, as residents, it's everywhere. But I know that surgery has this reputation, right? It's tougher. It's, what do you think that is? Where does it come from?
I think it's a lack of coming to terms with our own ego and our own weaknesses. And so what we do is we create a persona that's not authentic to our true selves. And, we're faced with a number of challenges that are unique in our field of medicine. For example, when we operate, we're technically doing something. We're using our hands. We're putting patients under anesthesia. They are trusting us to a very sacred situation where they turn over control to the anesthesiologist and the surgical team to execute the plan that's been discussed. But patients can suffer harm from what we do. They can have complications. They can die. And any surgeon who's been in the game long enough has had all of those things happen. And so when we need to keep going, you have to toughen yourself in a way that allows you not to want to quit because these awful things can happen. Your confidence in yourself gets taxed when these things happen, both by you've let yourself down when something has occurred, but also the scrutiny around you by your colleagues, by anyone who's interfacing with that patient knows that this complication happened at your behest. And so I think what we do is we create this persona, and we need to be a bit we need to broadcast to the world that we're tough, we're capable, we're Teflon, we're impermeable, that we're not taken down by these emotionally traumatizing situations. So we watch what our mentors and our predecessors did. And we see that as the only way to be in order to keep going. And this, you take it back even to the early days of surgery, and think about William Halsted, who was at Johns Hopkins back in the earliest days of surgical training. In fact, he's considered the father of surgical residency. He was loud, and he got his way. And interestingly, he was a cocaine and a morphine addict. Right. And so what did he do? He stimulated himself to keep going. So he didn't have to sleep and didn't have to take a break. And then because he couldn't sleep, or because he didn't feel, well, he medicated himself with morphine. But we exalt this gentleman as like a unbelievable surgeon. And maybe he was from a technical standpoint or from a visionary standpoint in the techniques of surgery. But that's not the model that we need to be looking at and emulating. Right. And so you see that, and these are the people's faces that go on the walls of the halls of our training facilities and our universities. And we don't look at the ugly underbelly of that. And so, we've been focusing more than ever in the past decade or so on physician well-being and health. And surgery, I think, has been the last, bastion to really say we've got to make sure our surgeons are healthy in a transparent way, because addiction is really high amongst surgeons and anesthesiologists. They're more than males. Female surgeons have about a 25% chance of being alcoholic. Is that?
Female surgeons do?
Female surgeons.
Wow.
And addiction runs really high amongst surgeons, and it's not even just with substances. It might be addictive in your anorexic and bulimic tendencies, over exercising. Boy, I know that from being an ultra athlete. Bad sleep leads to using caffeine in excessive ways. And we have this personality that we don't want to let people down. So we use ways to keep that persona of being impermeable or being, impenetrable, to keep it, in the forefront. And the reality is we need to do that internal work. And when you start doing the internal work as an individual, and especially as a surgeon, you start recognizing that how can you give to your patients health, healing, and you don't have it yourself, right? Mm-hmm. I mean, there's an old adage, you can't give what you don't already have. The Buddha said that, and it's also a Latin phrase. And it's how can you expect patients to take your advice about sleep, about eating, about exercise, and what have you, when you're hanging on by a thread? Yeah. And as we're training, if you showed any of those tendencies, people made fun of you. Or they're like, oh, well, so-and-so had to go and take a nap or go to sleep. No, let's be genuine about, we want patients to be healthy. And surgeons and physicians can't be patients. Oh no, we all are patients. Just depends on when.
We're human.
We're human. That's right. So.
Yeah, definitely. It's interesting. It's like that badge of honor, you're on call, you don't sleep all night, you've admitted this many patients, you've done, we've, been through that. And like you said, in the more recent years, there have been some significant changes in work hour regulations and starting to acknowledge that. But it's interesting because, sometimes I see these health and wellness initiatives for physicians and medical providers, and they're all well-intentioned. They make sense in some ways. But I think that much deeper work is really required to do what you're talking about, right? It's, we can meditate, and meditation has many benefits, and have wellness events, right? But it's really that deeper work that exposes and puts us more in touch with what are all these coping mechanisms that we've been using that are maybe maladaptive in the long run? How is that affecting us, our mental health, physical health, our patients, our loved ones, right? How is that affecting the overall environment in which we're working, right? It's not uncommon to hear, what you shared about, people yelling in the OR or having a bad temper, and how does that affect people's general sense of well-being and ultimately outcomes. And I think that that much deeper inner work, right, is required to really start to unpack that and kind of allow ourselves to be human, right? Because here you're talking about potentially over the course of a career, many things that can be outside of our control, many terrible outcomes. And again, no one is perfect, right? We can only do our best. But then to not punish ourselves or to not have these maladaptive qualities and these expectations that are unrealistic and then not address it. It's interesting. I was recently re-listening to a podcast that was re-released by Peter Attia, where he interviewed, I believe her name is Annie Duke, who is a poker player. Have you
Yeah.
listened to this? They
Oh,
talk
I
about,
don't know
yes.
that, but I absolutely know who Annie Duke is from the, World Series of Poker. And
Yes. So she talks about thinking in bets, I think was the name of the book. And she talks about decision making and all these algorithms. And in one part of the conversation, they talked about, or Peter mentioned morbidity and mortality rounds, right, in the hospital, and how we have such a negative bias to discuss very importantly, very important topics of, why did this happen in this case? What were the errors that lined up that resulted in
right.
such a bad outcome, right? Which is so important to analyze. And, we've all been through these conversations, and this can be very productive, very helpful, and ultimately is, again, good intentions. We want to improve patient outcomes. We want to learn, we want to analyze and understand it. But then at the same time, we're not really sitting down talking about, wow, why did this case go extremely well? Or maybe this case went really well, but could it have
Right.
gone even better? We don't talk about that.
No,
We don't,
no.
we don't orient ourselves the other way. And so if we're constantly just thinking about that, our negativity bias and how to avoid the worst and how to, they make a really great point about, how does that affect our decision making if we're only thinking about how to avoid the worst outcomes? Like we really have to look at probabilities and analyze. Anyways, I'm not gonna re-summarize it's a wonderful podcast, but it just reminded me of what you were talking about, because that's exactly what we focus on in the healthcare setting of just looking at those negative outcomes as opposed to looking at the whole spectrum and overall using that to improve our care, but also to kind of have a more realistic picture of what we're doing right and maybe what we're doing wrong.
Well, the interesting thing about morbidity and mortality rounds, which, for you or for other viewers that haven't sat through that extensively, is it's historically been very punitive. So when you are on the stage talking about something that went wrong, you feel the criticism of many people, and fingers are pointed, and it's changing hopefully in the more modern years, but it can be a very demoralizing and frightening podium to be at when you're admitting what went wrong. And the truth is, when you're a resident, as your chief residents are usually the ones presenting, it's not ultimately their fault. It's the attending surgeon whose patient, they're really truly responsible for it. But there's a lot of stress while you're presenting what you did wrong, such that you feel like it's an ego hit, it's a confidence hit. And so what do? You rebound by behaving like I described, the complete opposite way, like that you are impenetrable, afterwards, and then you get short with people, or you protect yourself with a way of being as a way to dodge the vulnerability that happens when things go wrong. And so it's interesting, because as of the past couple of years, something that I've decided to do is, when you hear about something having gone wrong, I usually reach out to somebody that has had that issue with a patient. I remember a colleague at another institution where the patient had died, and everybody in the department suddenly knew. And I just called that doctor up, and it was a younger person. And I said, I really feel sad for both, what's happened here, for your patient, her family, and for you. I just want to let you know that, number one, you are still a good person, that you are still a good doctor. And lastly, that we're not measured by whether these things happen in life, because they do, at our hands in the hospital, but we're measured more by how we manage the situation and how we move on. Because if you let something go, if something's gone wrong and you give up or you hide from it, that's when we've served the patient and ourselves the worst, right? When bad things happen, our instinct is to run away. But I always tell people, when you feel like running away, run towards that situation, run towards that patient, because they need you so much more than you actually are recognizing. It's not the time to abandon somebody. Your ego is ailing, your emotions are unchecked, and you feel awful. But go and be with that person. They need to see that you feel that much about them. Because if you keep your distance and you only go and visit on occasion, it gives the appearance that you don't care, even though we know that you care deeply. You just have to let yourself feel that vulnerable. And it is a hard thing to do. It is a very humbling thing to do, but this is part of that deep work. If we're always just, not addressing how we felt when something bad happened, we're just glossing over the situation. There's so much learning that can have emotional learning, spiritual learning that happens when things go wrong. And we've just never focused on it as a field of medicine, saying that this is so important to do that deep dive, to pick that scab, to really, look under the hood here and figure out what's happening emotionally that can allow you to process this and then move on and then keep working. Because when bad things happen, I think it contributes to burnout too. And as you can only imagine, when there's so many negative emotions floating around and you don't know how to process them, you feel like you don't have the emotional capacity to continue. And I think this is where we see people deciding to take a leave of absence or change careers or, drop out of the fields that we really need good providers in.
You're absolutely right. There's so much shame and guilt that's unresolved, unprocessed, and then that is automatically tied to self-worth. And I can see how when it's not processed, it kind of leads to one of two things. One is, you have the coping mechanisms that you initially described, which is like, well, then I'm just going to kind of let my ego take over and pretend that, nothing happened. And and then the other is to run away and say it's like a fight or flight response. It's like our sympathetic nervous system is dominating and saying, fight or just get out of there and don't resolve. Yeah. So I'm curious to hear kind of how do you in your life, or how did you come to kind of recognize and then ultimately engage in practices that allow you to have this sense of being centered and really aware of these things and then be able to work on them ultimately?
I think you have to, well, at least for me, it was a sense of hitting rock bottom. And I've told this scenario or the story a few times about distinctly recognizing when my life was out of control. And, I think we all have addictions. My addiction was work and still is, but I try to manage it better, right? But I remember driving to work and I was on the highway and there was some construction and it was 5 o'clock in the morning and I had not seen my children for 4 days. I lived in the same house. I slept in the same house and I hadn't seen my 3 children or my husband for that much. And being in this traffic, waiting to go to work at 5, in the morning. And I had this strange thought come to my mind of, I understand why doctors commit suicide. And I thought, I wasn't feeling suicidal, but I thought when you get to that point, when you don't know how to extricate yourself, you start to realize people start thinking that way. I don't know how to cut back. I don't know how to manage everything. It's so overwhelming. I don't know where to start. You'll think of solutions. People think of, medicating themselves. But I have lost colleagues to suicide. And it is a really devastating thing. I had never had that feeling or that understanding until I was driving one day to work. And I said, I've got to do something differently. And so this actually prompted eventually me entering the fellowship in integrative medicine, was recognizing that a big part of the fellowship at the University of Arizona is doing that personal inventory. It's the first part of our training is to do that deep dive into, all the basic needs. Are we even meeting our basic needs of breathing, eating, sleeping? I mean, that's just a starting point. And when I recognized that I slept on average 4 hours, 4.5 hours a night. I didn't really eat much because I didn't have a lot of time. And then I'm somewhat particular about what I like to eat. I don't eat, fast food and things like that. So I didn't eat much. So I was undernourished. I drank a lot of caffeine and I felt awful. And I hadn't really exercised as I've been an athlete my whole life. I hadn't exercised for months in an organized way. I just felt fractured. I felt absolutely just a shell of who I was when I entered medicine. I knew I needed to do something differently. So as I started the fellowship, we do all of this work of looking at ourselves, turning the mirror on ourselves, and realizing that I need to start prioritizing a lot of simple things. And I also need to learn how to say no to asks, because as you well know, as a physician and a mother and a spouse and a friend and a daughter, we have a lot of asks on us all the time. And when we're good at doing things, we get asked to do even more. And so I needed to start saying no to some projects. I needed to schedule my clinic and my operating room in a different way, where I gave that focus of quality time, not quantity time. Instead of seeing 30, 35 patients, which I commonly would see in the clinic, I see at least half or less than that a day, so that I can focus my time on the quality interaction that I have with patients, and that I'm not spending my whole weekend doing notes and following up with the details that happen. But you feel compelled to see patients and have big numbers, because this is part of the braggadocio of surgery is, oh, I saw 40 patients in clinic. I did 40 operations in the week. The braggadocio, the sense of you're not worth, your self-worth as a surgeon is based off of numerics as to these extreme numbers. By pushing yourself to the extreme was the only way that you had value. And I honestly felt that way. I would feel on weeks when I didn't have much to do, I felt terrible about myself. Felt like I didn't work hard enough. I didn't deserve to have time off. I didn't deserve to get a full night of sleep and to take my kids to school, even though I wanted to. It's a weird push and pull that you get when you get in that mentality. So I needed to break it. And I think the tools that I learned in our fellowship started that process of looking at, where does that need come from? What is being unmet that I needed to do that to feel valuable? And it's so eye-opening as we look at our own selves with a microscope, where that comes from. Is it the need for attention? I think I craved attention as being one of many children in a family. I wanted to be an overachiever because it gave me positive attention, and I became very singular in that respect. I wanted to be a doctor, but I had a kinship with my father, so I got special attention because of that. And so you start realizing you need to understand where that self-worth comes from, because it drives a lot of these addictive behaviors. Where do we get that sense of love, sense of self-love, but also love from others? And do we need that to feel whole? When you're in our field, being able to have these big numbers and lots of surgeries and be known as someone who's hyper productive gives us positive, I would say from our historical lens, gives us a positive glow about being somebody very special. And the reality is, I wanted to be someone who delivered the highest quality of care, not the highest quantity of cases. And the quality had to be up there first and foremost. And I needed to scale back on so many levels to do that.
Mm-hmm. And have you found that through this process of discovering this, through the Integrative Medicine Fellowship, it sounds like in one example you shared, you've significantly cut down on the number of patients you're seeing so that you can really focus on that quality. I'm curious if you wouldn't mind sharing how it's affected other areas of your life as a mom, as an athlete, how your sleep is now, has that kind of affected these other areas?
It's affected it in a tremendous way. And it's not that you go and you've fixed your situation. As many people know who live with addiction or come to terms with that, it is a process that you look at every single day of your life. I have a number of these sort of tendencies that I have to keep in check where I revert to some of those behaviors very easily, and you've got to drag yourself out. And one good way to keep yourself in check is to have a colleague who helps keep you in check. My physician assistant that I work with is incredible in that she will remind me to eat, to drink, and also, you've got too many cases booked for this week. You need to stop. And I was like, okay. And so if you don't put it out there for people to, keep you honest, you have an incredible tendency to go back to these behaviors that we have, made a part of our DNA. And I don't want to do that. But in regards to family and, caring for my children, I can't tell them to do these things in life, to eat right, to sleep right, to exercise, if I'm not doing them. I need to be a model for that. And that is something that you recognize the hypocrisy in when you are telling your children, you can't eat that, or you need to eat breakfast before you go to school, and then you're not doing it yourself. So, once you start to decide that you want to change, that change has to be both at home and at work. It can't be that you're just going to, at the hospital have lunch, and then at home you're going to do whatever you want. So, but getting back into the rhythm of sleeping has changed my life in ways that I can't even put into words. I read Matthew Walker's book, Why We Sleep. It should be part of medical training. It should be part of the literature that we're asked to read when we're starting medical school. And it would put everything else, you'd organize your life in a way that you prioritize that because it's good for your health. And there is a way to sleep. I have to schedule my life in a different way such that I'm not trying to be at the hospital too late, and that I have a stop time when I'm going to sleep. And then I get up in the morning. I don't set an alarm clock anymore, which is really interesting. I never set an alarm clock. I go to sleep and I wake up at the same time almost every day. Unless I have something really, really early, I don't set an alarm clock. So prioritizing sleep has changed things in a major way. And then putting exercise back into my life, but not in a punitive or a masochistic way, right? I used to exercise till I felt like completely exhausted. I'll give you an example. When I was a resident in Boston in surgery, I ran the Boston Marathon 4 times. So 4 out of my 5 years as a surgical resident, I was running to qualify in a race so that I could run the Boston Marathon, because I thought if I could push myself physically to run marathons fast and do all that, there's nothing that surgery could do to me to bring me down. And that's not the right way you should be thinking, because then you're conditional in the love that you're giving to yourself. Like, only if you do this, do you deserve this. So I was into ultra running and marathoning and all these, excessive things. Now I do things regularly, but to make myself feel good, right? To put the joy back into movement and exercise, and not for it to be a measurement of whether I deserve something. Mm-hmm. So when you start to actualize the things that you're talking about, you see that play out in your personal life in ways that are really marvelous. My children know every night I get home, I go swimming. And I have been swimming in cold water and in regular water now for 185 straight days, but not in a way to make myself exhausted, but by making it a habit of something that I do that I love so much that it reinvigorates me. And I do stretching. I don't run marathons like that. I don't try to break records. And that was my instinct, growing up, that unless you could do something like that, you're not an athlete. You're not worth it. And that is the self-love that I needed to get away from that vision of self-love and recognize that I was good enough without it. But that's a hard place to go to when your whole life has been organized around, what your value is.
It's so true. It's, when we examine parts of ourselves that help us succeed and excel at something, and you have a track record of all these accomplishments, and this was part of how you came to this place. As you're examining them and seeing maybe some of the maladaptive aspects, it's hard to say, oh, wait a minute, I got to do some rearranging here, right? And so it's such a balance of true acceptance and appreciation for what these parts of you mean and where they've gotten you to, and not wanting to suppress them, not wanting to suppress those urges or suppress the instincts that you have, but to maybe start by allowing for there to be a little bit of space before you act, or say, well, wait a minute, what are other parts of me wanting or saying? Or and the reason I'm using the word parts is that internal family systems therapy is something that I've come to be very familiar with, and something that I've personally engaged in. And I think that this framework is very helpful when we're wanting to kind of, I sort of want to use the word critically, not critically as in, oh, you're so bad, but critically examine, as in just analyze, and go deeper into, wow, how did these parts come about? And, you mentioned the relationship with your dad and wanting that attention and wanting that girl, wanting to be special and do something really meaningful and impactful. And what a noble goal to have. And then kind of at this stage in your life saying, I value and appreciate that and where that has gotten me, but I'm just going to kind of do a little bit of rearranging and recognizing some of the other parts that are calling out to me and tend to them and support them. So I think that's really beautiful, the work you're doing. And thank you so much for sharing that.
It's not the traditional way that we come to that knowledge, right? I mean, because we're not, unless we have mentors that are really transparent and teach you through their ups and downs, their zigging and zagging through life, right? You have to do it on your own. And, it's interesting, during our small group sessions last year, I had surgery and a major operation. I had a hip problem my whole life and eventually had a hip replacement. And I remember learning so much about the journey of surgery through my own surgery. Even though I'd had other things done, this was a really formative time for me, and transformational time that I wasn't even expecting, because you recognized how vulnerable you are when you're not well, when you're in pain, when you're recovering. And I thought I understood that with my patients, but sometimes it takes really being in that center spot to recognize how everything works around you. And when somebody says something, you prickle because it's not well received. And so I understand the value of the words that I'm using, the choices of when I'm talking to patients, of how I address the condition that we're talking about. I've sat in that patient position, and it changed me on so many levels that I can't go back to who I was before. I now look at my relationships with patients as both a provider patient talking to another patient, because it's not just me arriving and saying, hey, guess what? I'm here to fix you, because that's not the role of the surgeon. I don't believe it to be the role of the surgeon, is to come in and fix people. Because when we say that, kind of like in the words of Naomi Remen, when we say somebody needs fixing, we're telling them that they're broken. right? And so when I had surgery, I had a distinct feeling that people were acting like I was broken. And I didn't like that. And so when I talked to my patients, I really tried to build up those innate qualities and healing capacities that they have that showcase that they aren't broken, right? You have a condition we need to manage, and a lot of it's going to come from your acceptance of the situation and the work that we do with understanding your condition, where it started, where it's led to, what you can do at home on your own with your family to change your healing. It starts with you. It doesn't have to be that you come to my office and I tell you that I'm going to fix you. And that's the training we got, though, was you're a surgeon, you fix people. And in fact, you will have, or I'll have, students interviewing for residency that'll say, I always just like to fix things, and that's why I want to become a surgeon. And it makes my skin crawl, because I'm saying, you don't get it. You really don't get it yet. And I'm also giving the grace to that person that this is a journey for them, that they're going to learn that you're not here to fix somebody. But we need to walk with that person and serve them in a way where the surgery happens, but they are the main healer in this arrangement. We've never empowered patients like that as surgeons. We need to. And this is part of this integrative surgical model, which is to really emphasize to the patient that they have so much capacity for getting better within them. They don't need to look for it externally.
Definitely. And I think that when you, as a medical provider, allow for that relationship between you and the patient to be, two equals. It's not one person talking at the other person, and as you said, fixing, and this is so true of the general integrative medicine model. One of the first things in the fellowship is let's define integrative medicine, right? Because a lot of people have different definitions. And one of the central things of that is that the patient is at the center, but it's really about that patient-provider relationship. We're not, asking people to comply passively. We're really learning about them, partnering about them, co-formulating plans with them, and supporting them to heal, empowering them to heal. And that was in a very different situation, and not a surgical situation, but that was one of my first encounters when I was a resident during my pregnancy. The contrast between kind of the standard of medical care. And I had a wonderful OBGYN. He was fantastic, but just the contrast in general to the standard medical care and the integrative medicine providers I was starting to see, who I really felt empowered by and who I really felt believed in me. And I think for your patients to hear that you believe that they can heal, and of course you have the skills and the tools and the knowledge, but you truly believe that they can heal, and you believe in their own power to do certain things, to have agency, to that their body knows what to do to heal is huge. It's tremendous. I don't know that we can necessarily quantify that. I don't know, maybe one day there will be specific metrics where we can really quantify that, or quantify that in outcomes. But I really do think that as something maybe intangible makes such a huge difference for the patient's outlook when they know there's that belief and that empowerment.
Absolutely. And then we think about all the education we get regarding even the placebo effect, right? When you believe in something, even if it's not, really changing chemistry or pathophysiology that we can measure, when it works, it works and it's undeniable. I'm not suggesting that we need to instill the placebo effect here or do placebo surgery or something, but the point being is that if strong belief can impact the way that we heal, why have we as providers not verbalized our belief in that? We've just said, well, you're going to have surgery, and then the healing time is 4 to 6 weeks, and blah, 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 blah. And patients will ask me this all the time. How long will it take for me to heal? And if you'd asked me that 15 years ago, I would have said, oh, like I just told you, 4 to 6 weeks, da, 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 da. But now I tell patients, healing is a complex state of being. And if you're asking me about the incision will heal in this amount of time, and you'll see a scar that remodels itself. And by this time, you'll be feeling like you have the integrity of the wound is at its final healing stages. But if we're talking about true healing, we're talking about something that's a bit more internal. And I tell them this. I'll say, your healing may take you several weeks, it may take you years. Because when we talk about surgery, depending on what the reason for the surgery is, as I alluded to before, we're talking about a traumatic situation. And that traumatic situation might even start the moment you hear a diagnosis that requires surgery. So getting the diagnosis of cancer, for example, the trauma has started the moment that there's been symptoms that led to a diagnosis, or if the report came back and you're given the results of a test that tells you that. That is when that traumatic experience begins. And as we all know about all kinds of trauma is a longitudinal thing. So that trauma can be worsened by the surgical course and the actual operation and the healing, or it can be made better. And then we have to think about the phases following the actual surgery into that rehabilitation and or palliation phase of surgery that helps us manage the trauma. We don't get rid of it, as we're well aware. And I can say, even having been someone gone through surgery myself, I still feel the effects of that surgery. I still reflect on what it was like to go through that. I still have some symptoms that remain with me, and they may never change. So a lot of the conversation with patients about their healing is giving them that broader perspective of what it means to heal. And I kind of reflect on the, I want to say it was like the World Health Organization that once gave a definition about whole person health. And they said, whole person health, or that state of healing, is a state of physical, mental, and social well-being, and not merely the absence of disease or infirmity. And so from my perspective, if you're still have lingering symptoms, or you have pain where an incision was, or you have digestive issues that aren't normal compared to the way they were beforehand, you can still have whole person health. You have to be able to manage the impact that those symptoms have on your life, but you can still be a healthy and healing person. That's not a conversation that we ever had in medical school or in surgery. About it was either you had surgery and then you were fixed and you healed in 4 to 6 weeks. And if you had any lingering symptom, there was something wrong. Now, that's not my experience personally, and it's not my experience with my patients, is that we need to normalize this being a longitudinal experience with surgery, and it not being something that has a start and an end date that we could actually put an actual number to.
I couldn't agree more. And, even in people with non-surgical conditions, there is such a spectrum. And I've come to appreciate more and more, the longer I've been in integrative and functional medicine, I'm seeing more people who may have unusual symptoms, atypical symptoms, and unfortunately feel very much dismissed by the medical community of, well, I can't help you, or your labs look fine, so you're fine. And that's not the case. We know that's not the case, right? And so oftentimes, if we don't find a concrete, specific answer, a lot of a lot of the times people may feel dismissed, even if that's not necessarily the intention of the doctor. Right. And, and sometimes it may come from that place that we talked about before of we want to fix things, we want to identify, we want to treat, we want to diagnose, and we want it to be a clear path. And often it's not, because our body doesn't read the textbook. We're all different. We're all on a certain spectrum of conditions, and having the understanding and the compassion and those shared conversations and is so important, because number one, you never want to dismiss a patient. And if they're having true symptoms, it's from something. Maybe we don't know yet what it is. Mm-hmm. Maybe it's physical. Maybe it's a combination of mind, body. Maybe it's trauma. Maybe it's something we haven't discovered yet. But there's so many possibilities that we're not aware of. And I think that being persistent in that search, being inquisitive, being curious, and just having the understanding that everybody reacts so differently. I'm sure you've experienced this in your field as well. If you're operating on two people and maybe on paper they're the same, but it could be a very different healing process, right, and a very different experience for them.
It's true. And the other thing is that we often just assume that all patients that come to see me have surgery. We take care of a lot of patients that we make decisions not to operate on, and they may have the same disease diagnosis that another patient has that needs surgery, but we have to decide who needs surgery as part of that healing journey, who needs to do other things, or maybe they haven't even started with some of the basic things that can help with their symptoms. Or maybe they have a medical history that really makes surgery not so safe, and to really set the expectations of what will happen after surgery. This is not a guarantee that 100% of your symptoms are going to be gone and that you're going to feel well, or that everything's even going to go well. You have to be very open about the possibilities. But I do agree with you in regards to patients coming to you with complex situations and feeling rather hopeless. One thing we can do is to instill hope by even having the curiosity to take the time to listen to what they're saying, because to feel hopeless about your situation is perhaps one of the worst things that a patient can feel. It seems like no one's interested, or they are dismissive, or something is so unusual or rare, or they're just telling you that it's not real. And we know from having enough patients that have unusual presentations that is very real. But what is real? Does it have to be a concrete, identifiable in a physical and a visible way that this is occurring? Or can it be something that's a little bit more esoteric, or like you're mentioning regarding the mind body, and or even a spiritual? Actually, I have a great story I can tell about a spiritual situation that presents in a way that is quite unusual. I have a patient who came to me who had a legitimate surgical condition, needed a part of the bowel taken out. She had chronic pain for many, many years. And she went through her surgery, and then she woke up, even having a big incision, long operation. She said, we fixed it. And I said, what do you mean we fixed it? She says, no, well, you got rid of it. And I said, what are you talking about? And she said, I have been living with this internal demon for many, many years. And I was thinking, what? I didn't do an exorcism, right? What is going on here? She said, no, I had this intestinal problem that really was the seed of all of my anxiety, all of my pain, all of my trauma. And I attribute it to my diverticular disease. But what I'm realizing is it was something that had happened to her as a child. and she had suffered a lot of abuse. And she tied these two conditions together: stomach pain, irregular IBS-like symptoms, diverticulitis, which she legitimately had. But she said, I get it now. Like she said, I don't know if I would have known that if I hadn't gone through surgery, but I believe I now know what was at the root of my problem was I hadn't addressed this trauma, and she'd never talked to anybody about it before. And it just it came as like a revelation to her after undergoing surgery. And of course, that wasn't the fix. It wasn't like we just fixed everything. But surgery can be something that helps a patient get to another chapter of their healing when they have a legitimate problem. She started to reflect in a different way on getting counseling regarding the trauma that she had been not managing and not addressing. She started to change the way she was eating and the behaviors that she had. But if I hadn't been open with her about the experience of surgery touching us in all those ways, physically, mentally, spiritually, I don't know that she would have offered that up to me. And I think she would have felt that I was dismissive about that being even a part of her condition. But it's just really amazing when you start to even ask a patient the question of, why do you think this problem happened, and where did it come from? Even if you ask a patient who's had cancer, why do you think this happened? And I got to be honest, this came from the reading that I did by Louis Mel Madrona in his Coyote Wisdom, Coyote Medicine, him asking the question, what good has this diagnosis done for you? And it's such a baffling question because you never thought to even ask it. Patients will say the most remarkable things. It gave me perspective on my life. It showed me that I was not paying attention to all the basic needs that I had. It revealed to me that this relationship that I'm in is toxic. I felt obstructed emotionally, and I was physically obstructed with a tumor. Now that I'm recognized this, I can make both of these things better. But it's a little bit of that relationship that you build that allows a patient to reveal, what is ailing them truthfully. It's not just a problem with the bowel or, a tumor. It's much bigger than that.
Yeah, and to feel safe in sharing that with you, I think that's remarkable that you open that safe space in a surgical office for them to have that safety, but also to it's almost like you take them from a parasympathetic dominant, right? If they're in a feeling of trauma, anticipating, okay, I'm going to now have this possibly invasive procedure and whatnot, and you take them in the parasympathetic of like, let's take a step back. Let's think about the connections here. Let's kind of search for meaning, right? I mean, we're human. We want to kind of find a deeper meaning. We want to grow and learn from an experience, even when it's traumatic or tragic, or and I think that you offer this wonderful way to do that. I know we were talking about Coyote Wisdom earlier. I'm curious if there are any other interesting pearls from Dr. Madrona that you might use or that you might have learned.
One of the neat things, I'm in the throes of reading his book, Coyote Healing, and it's about miracles in native medicine. And he talks about, traditional medicine being very dismissive of this concept of miracles, things that we can't explain, and recognizing that things like this happen all the time. And we have the choice in life, much like Albert Einstein would say, you can either believe that nothing is a miracle or that everything in life is a miracle. You have the choice to decide how you want to view the world. But when you start to recognize that there's so much magic and maybe unexplained energy and possibility that exists in the world, we aren't tapping into that unless we allow it, unless we broadcast that we are believers and we are a safe space, like you're saying. He mentioned in his book something that I have taken to heart, which is when you're healing and trying to work with a patient to heal a patient, you're actually healing their collective family and their community. And as one can imagine in the native culture, community, family is so important, but it's not an idea that we've done much work in, is understanding that when you're working to heal somebody, you are healing their loved ones who care for them. And so it's not just a one-on-one situation. I mean, it might be if the person is really disconnected from family and friends, but that's so unusual. But you're healing a broader context of individuals, and you have to keep that in mind because we are asked to do a lot. We're asked to care for patients and to respond to phone calls and all of this, but they're so important to take their concerns seriously. When a family member needs more explanation about something, I don't hesitate to get on the phone and call them because I'm recognizing that that person, the patient's healing, is also so important to that family member. And the family member can actually help with the healing when they understand more too. So Dr. Mel Madrona's books have been very influential to me in looking at the impact of being a healer, or of the impact of trying to do that work with a patient is not just as limited as we're taught to see it as patient-physician interaction. It's actually a much broader experience.
Yeah, that's such a good point. That's very interesting. So we've talked about different aspects and different examples of how you approach patients and how you approach your own presence, in the OR and before and after the surgery. Can you maybe, before we finish our conversation, kind of take us through what it might look like for a patient if they're coming in to see you? What are some of the things that you generally kind of think of in that prehabilitation phase, the perioperative, and then intra, post-op, and that rehabilitation phase? What are some of the things that maybe people listening can also take away and maybe even advocate for themselves in a surgical visit?
Right. I think this is important for our listeners to take to heart, is that the advocacy for oneself is so important. And if the interaction or the relationship between the surgeon and you is not therapeutic, you have choice. You should have choice. You do not have to have surgery by someone that it doesn't feel right. And I think that hopefully you're not in a scenario where you live in a very small town and there's really not much choice. But I always tell patients, seek second opinions, seek as many opinions as you need, but find and rest in that therapeutic relationship that's going to allow you to do that true healing. Because if it's not with me and you find that with someone else, that's perfect. Because I want that. You need to feel confident in your decision. It isn't that I'm doing something to you against your will. It needs to be that we come together in a mutual decision to move forward. So the prehabilitation inquiry during this visit with me is going to cover a lot of the things that we already discussed. We'll go into detail about the diagnosis, the data that we do know right now, the decision making regarding treatment options, and then we really turn the lens onto the patient to understand those what are they doing right now for their own health, and exploring the basic things like sleep and eating and hydration and movement, spiritual connectedness, breath work. It gets pretty broad, and sometimes it takes over an hour or more to get through these consultations because I want to make sure we hit on all of these topics. We do provide a lot of paperwork in advance so we can get some feeling as to where patients are and what their needs are prior to them arriving to the clinic. And we do a preoperative psychological survey that gives me a kind of a snapshot as to how patients are feeling regarding hopelessness, the energy to do things, the sadness, happiness, where's their mood right now? That's not meant to be a scale or a a way to truly quantify it. It is definitely a survey that just gives me more information as I start this relationship with the patient. Once we've addressed those things, we then talk about what do they need to do to actively prepare for surgery, and then clearly go into the details about surgery, the risks of surgery, the technical factors that they should be aware of, and what are the potential postoperative complications. I like to give people an expectation as what's going to happen on the day of surgery, or the day before when they're doing their preparation, and then what happens when they enter the hospital. Who are they going to see? Who are they going to meet with? And then when the day of surgery does come, is to make sure that when I'm approaching that patient, that we're working by toning down the sympathetic response. We do a lot of work with aromatherapy. We're starting to do more work with guided imagery, and our preoperative interaction in the waiting area also involves what I call an intention setting ceremony. And this is for patients that you can gauge that are receptive to this, and patients that are not wanting this. I don't push it on them. But our intention setting ceremony involves basically gathering as the team of providers that's going to be there with that patient, from the pre-op area to the intraoperative personnel. And then we include the family that's at the bedside, and obviously the patient. And what we do is I take a stone that I have that's in the shape of a heart. And I start by telling the patient what my intention is for the operation, by executing the procedure well, by keeping them safe, by helping deliver them to the other side of their surgical journey when the surgery is done, and to care for them throughout this process. And then the stone gets passed around to everyone there. And then lastly, it goes to the patient, and the patient gets to tell us what their intention is for the surgery. And then I take the stone back and I place it in the pocket right near my heart. And I tell them that I'll keep it there during their whole operation. And it's really remarkable, this intention setting ceremony, because it's something it came to me through reading about ceremony and reading about traditions that are really strong in ceremony, and recognizing that there's no reason we can't create our own ceremony that has meaning and use that in the pre-op space. It brings most people to tears. It's a cathartic experience that allows patients to go in feeling less anxious. The families respond so strongly to it because they're hearing how much we care about their loved one. And this is in a time when it feels rushed, right? That's a pause. It doesn't take us longer than 2-3 minutes to do, but we're pausing, and then we're turning our attention directly on that patient to tell them what we hope and wish for during this surgery, as well as their healing afterwards. And so that's part of that perioperative phase of their journey. And then intraoperatively, we need to be really mindful that even though patients are going to undergo anesthesia, they need to enter the room where the sympathetic tone is also decreased by not having loud music on, or have music on that's soothing, that's of their taste and of their choice, that the conversations are kept in more of a lull, and it's not loud talking, and it's not multiple people talking to that person at once. It's usually one calm voice instructing the patient what to do. And then as they go to sleep, to really honor that moment in which they're drifting from consciousness into unconsciousness, that time they're very vulnerable. This is a liminal world, right? Like where we're passing into that threshold of being unconscious. Honor that. And the patient's journey is off to such a wonderful start, because we're not making it seem like it didn't matter. And I'll give you an example of a really beautiful scenario where I had a patient who was pregnant and had a colon cancer, and the baby was not of a viable stage yet, so that if the surgery didn't really go well, the potential to lose the baby's life was there. And so we spent a lot of time really working in a spiritual way to prepare this patient for surgery. And one of the things that I did very deliberately was I brought in a colleague to help me with surgery who was also a mother, and I'm a mother. The anesthesiologist or the team around us had, I think collectively had 13 children of the people that were working with her. So we brought the mother energy into the room. We did some aromatherapy prior to surgery, and then she wanted to listen to her favorite gospel song as she went to sleep. Oh my gosh, I could barely not cry rolling in there. And it wasn't because I was sad, right? It was because you felt so connected to the life force of what was going on there. And she fell asleep with tears streaming down her face as she's listening to this song. And it was so beautiful. And that's an opportunity that we never focus on as being so pivotal. And then, of course, she woke up, the surgery was done. She went on to deliver her beautiful baby. And I look back on that and go, would the outcome have been different if we hadn't paused to do all of those things? I don't know. I wouldn't want to know. Because to me, it felt like the most perfect thing we could do for someone who was obviously afraid. And it was a time where I felt for the first time in my life that I had basically three people's lives in my hand at once. Mm-hmm. It was obviously the patient, and it was the baby's, but it was also her husband's. Mm-hmm. His loved ones were right there in my hands. And if I'd done it in a different way, who knows, right? So there's much that we can do in this space when we empower ourselves to do that. Mm-hmm. And then we allow for that magic, as I was talking about, the magic, the miracles in medicine to play themselves out. And so that to me just registers as a really pivotal experience that we had.
What a beautiful story. Wow, what you did for that family, right?
We tried our best, right? We put it forward in the most important thing was not the surgery. The most important thing was that spiritual connection for her, mm-hmm. right? And when you honor that, and I remember telling her, the most important thing here is that you do what you feel is right, not for me to tell you in a very paternalistic way, you need surgery. You need to let me take out this, X, Y, and Z. You need to, no. Do what you feel is right. I've laid it all out for you, but come to that decision on your own. And then it feels like a real moment of healing as opposed to, being forced into something against your will.
Yeah. And that's where that empowerment comes from. It was her decision. You provided the information. You provided, again, a space that was going to ask about her values, consider her values, and include them in the treatment plan.
Right. So that's getting you through the surgery. The rehabilitation part, as you are well aware, can take quite a while to get to a point where you feel you're at a steady state. The rehabilitation involves all of those things we talked about: physical therapy, diet, exercise, spiritual work, breath work, the list goes on and on. Whatever it takes to get to that point where a patient feels this chapter is rounding itself out and that they can still reach out to me when they need to, but it isn't the frequency of visits that they need going through those moments.
Yeah. Well, thank you for walking us through that and then illustrating that really powerful example of what's possible and what we really should be turning to in medicine. And that idea of ceremony, I was first really formally introduced to it in our fellowship training. We talked about Anne-Marie Chieson, one of our faculty members, who is absolutely incredible. And I remember her sort of introducing the topic and practicing some ceremonies ourselves. And it's interesting, you and I had talked about ceremony before, and I was Googling it to see a ceremony in medicine, what had been written about it. The only thing that comes up if you actually Google this is white coat ceremony, of how we get our white coats. There's no actual, like if you just go on the Google search and try to, and I think, what a shame, because it's so much more, there's so much more to it than that. This is this kind of, label or artificial thing that was constructed, but ceremony is about so much more than that, and really creating that mutual spiritual space, as you said, for the providers and the patients, the sacred space.
It is, and there's a favorite line from a book that really changed my life back in college when I read it, and it's from the book by Milan Kundera, The Unbearable Lightness of Being.
I love that book, by the way.
He says, surgery takes the basic imperative of the medical profession to the outermost limits, where the human makes contact with the divine. And so the way I interpret this line, and obviously I know it so well because it's part of my own fiber now, is surgery is that liminal space where you've got consciousness and unconsciousness, where you are taking a patient and entering a very sacred location that so few people are able to enter. Maybe you have, women who bear children, or, a lover or something like that, but you are entering a space that's really only accessible, the inner part of our body, by so few people. And you're trusting me to do something that puts your life potentially in limbo, right? And so unless we recognize that sanctity, I just don't think we do it the service that it deserves. And, in training, even back when I was a surgical tech, before I became a resident and beyond, it was just about, clean up, turn over, and everything was just, so automated and impersonal. Bringing that personal touch back to surgery in this way is so needed. And you mentioned about Googling ceremony. I've done that. I've looked at it and I know exactly what you're talking about. The one caveat I would give is, when I was a resident, and then now knowing what I'm hearing in the hospital, but when a patient donates their organs, there is ceremony in the hospital, and many people don't know this, that we have healthcare providers line up against the corridor of the hospital as a patient is who's going to give their organs to someone else is going through that process. So it is a call to the people to gather. And there's also ceremony, for example, when I used to work in the VA hospital, that you would gather on the halls of the corridor as a patient who had died was being moved from their room, and it was basically like if you had like a flag bearing ceremony. And so those are the only two scenarios that I've really experienced as ceremony in the hospital. I guess maybe when babies are born, they play musical chimes in the hospital, but it's not really a ceremony. It's more of an acknowledgement of a new life coming into to being. But we need more of it. So reading books by Luis Mel Madrona, or even a wonderful book called The Scalpel and the Silver Bear by Lori Arvizo Alvord, who was the first Navajo female surgeon, period. She wrote a beautiful book about her experience of blending her Navajo culture with the allopathic medical world of surgery, and how she seamlessly has been able to do that and to honor all of these things that we've talked about. And she and I have become friends since I reached out to her and she gave a talk at one of the universities I was in. But learning from these traditions and then finding ways to make it authentic to ourselves. Just because we're not of a particular culture doesn't mean we can't have ceremony. We can create that ceremony that's meaning as long as it feels real and that there's some benefit to the patient and it doesn't just serve me as being someone who does ceremony. I want it to be meaningful and to impact everyone involved.
Yeah. And maybe just to finish off, I'm curious to hear a little bit about how this work that you're doing, and I know you're giving talks and grand rounds on this topic, how is it being received? And do you find that there's still resistance to this, or like, what is she talking about? Or are more and more people coming up to you and like, I want to do this too. Can you train me?
It's interesting. I just gave the talk to a group of neurosurgeons, and you're thinking, okay, this is the penultimate surgical, spectrum here when you're talking to the brain surgeons, right? I got such a warm reception by the neurosurgeons. They kept saying, we need to build out this program in our hospital even further. So I would say from those surgical colleagues, wanted to know everything about supplementation and diet and all of the breath work and the guided imagery that we were doing. They saw so much value for their own patients. And not only did they see the value, but it's actually the patients asking for it and they're listening. Patients want these things. I get a lot of patients coming to see me that want consultation just regarding an integrative medicine evaluation after they've been through treatment for cancer, for example. So it's more of an integrative oncologic consultation, but there are different areas of medicine where patients want it, providers are open-minded to it. And recently talked to a colleague at the University of Minnesota where I did my training in colorectal surgery. And he said, it's about time. We need to be embedding this discipline into surgery and exposing all of these concepts that make us better practitioners, that make us better people, that make us healthier as well. It translates into better outcomes for our patients and for the longevity of our own careers and the satisfaction with our own careers.
Absolutely, absolutely. And I'm glad to hear that there's more openness and more curiosity about it. And I think that it's also helpful to kind of in those conversations, I think sometimes when it's kind of harder to reach an audience, so many of the things that you've talked about are actually very tangible. When you talk about nutrition, when you talk about improving, if people have diabetes, or maybe they don't have diabetes yet, maybe they just have insulin resistance, you're still going to improve their healing. You're still going to improve their outcomes if they're able to make some changes to their nutrition before surgery. If you improve blood glucose levels during and after surgery, again, healing is going to improve. There are various mind-body modalities or even VR modalities that might be able to help with pain control, right? So there are some intangibles, like we said, that we know that there's this quality that is elevated for the patient, for the providers. But then there's some tangibles that it's like, why are we not doing this all the time, right?
That's right. I mean, and what are we waiting for? If not now, when, right? When is the right time? And I tell the story of how when I went into medicine, I even contemplated going into naturopathic medicine because I recognized the approach was different between allopathic medicine and the concepts in naturopathic medicine. And then I realized, well, they're not training naturopathic surgeons yet, so I need to go in this other direction. But if not now, when are we going to say that all of these types of healing traditions are valuable in one's healing process? When are we going to say that? Why are we conditional? And it's truly it depends on the mentorship that you've had and the people that you've been exposed to and the experience maybe that you've had with these sort of disciplines. But as a integrative surgeon, I've tried all of these things. I've done everything that I would recommend to a patient, and it ranges from, supplementation to shamanic journeying to virtual reality and guided imagery. When you experience those things and you feel it in yourself, when you're telling them that, it's not giving them some casual recommendation. It's a recommendation that comes from your advocacy from that personal experience. And so I would say some traditionally allopathically trained surgeons or even DOs might say, I'm worried about recommending these things because what if it causes harm? And they could be anything from supplements to dietary recommendations to, exercise. And you think, well, we're perfectly fine in prescribing Coumadin and psychiatric drugs, but we're not okay with these things. And it's because that we were never taught. We were never formally given that education to feel confident that our decisions were going to be helping patients and not potentially causing them harm. So I think when we empower physicians to take those steps and to use a broader, I would say, portfolio of healing modalities, patients benefit, but then they gain a confidence from their experience in their recommendations. It's just a matter of time, and you got to start somewhere.
I agree. Yeah, it's a process. It's evolution, right? And hopefully more and more physicians and groups are catching on. And I really hope that your message gets spread to more and more people, because I think that you're doing some really fascinating work, and people need to hear this. So thank you so much, Elizabeth. I really appreciate it. This was such an illuminating conversation, and I really hope people benefit from listening to this.
Well, thank you for having me. And as always, it's wonderful to talk to you, and looking forward to hearing what our listeners think about the topic.
Wonderful. Thank you so much.